right, I'll go ahead and get started. Um, Hi everyone, thank you for joining the Center for Learning Health System Sciences for our monthly Impact seminar. Before we get started, I'd like to cover a few expectations. Today's seminar will be recorded. You can enable closed captioning by hitting the Show Captions button next to the Raise Hand option in the Zoom menu. The public slide deck will also be made available on our website under the Learn With Us tab. I will post the link in the chat along with the short questionnaire asking for seminar topic and speaker suggestions. Following the presentation, we invite you to raise your hand or type questions in the Q&A. In particular, we welcome questions exploring the many dimensions of impact that these ideas, technologies, and practices have on learning health systems. As a reminder for upcoming LHS events, there will not be a seminar in September 2025, and we will resume the series in October. Additionally, we are hosting a Learning Health System Sciences conference in September on the University of Minnesota campus. I will share a link in the chat with more information on that. With that, I will turn it over to Dr. Genevieve Melton-Mew to introduce our speaker.
Good afternoon, everyone. I'm thrilled to warmly welcome and introduce today's seminar speaker, Dr. Adam Wright. He's a professor of biomedical informatics and medicine at Vanderbilt University Medical Center, and he is also the director of the Vanderbilt Clinical Informatics Center. And they affectionately refer to this as VCLIC and decision support operations there. His research focuses on the use of clinical decision support, scaling and sharing clinical decision support across organizations, and AI to improve quality and patient safety. He has well over 200 peer-reviewed publications. He serves as an associate editor for the journal Applied Clinical Informatics and has been a previous board member for the American Medical Informatics Association. In recognition of his contributions in informatics, Adam was awarded the Donald A.B. Lindbergh Award for Innovation in Informatics in 2023, and he is also an elected member to the American College of Medical Informatics and the International Academy of Health Sciences Informatics. We're thrilled to have him as this month's Impact Seminar speaker, and his talk is entitled The Learning Health System and CDS Governance and Lifecycle Management. So with that, thanks, Adam.
Awesome. Thanks, Genevieve. And I heard Genevieve mention the International Academy of Health Sciences Informatics. I wanted to quickly point out that Dr. Melton-Mew was inducted yesterday into IOSI. So I want to say congratulations to her for that. You guys have an exceptionally talented leader who's made a big impression on the field of clinical informatics, both in the United States and then also internationally. So you guys are lucky to have her at the helm of your learning health system. So congratulations to Genevieve for that. As Genevieve said, I'm Adam. I work at Vanderbilt, so I'm down here in the Southeast where it's pretty hot right now, although cooling off maybe a little bit for fall, and always enjoy visiting your part of the country, although I guess today I'm just going to do it virtually. But we are a large academic medical center, and like a lot of places, we use Epic, but we didn't always use Epic. So we have a long history here of self-developed electronic health record software, including our Star Panel and Whiz Order system for doing order entry. And these self-developed tools over the years allowed us to do a lot of experimentation in the sort of vein or style of learning health system in the area of clinical informatics. And so we would have an idea, for example, that we needed better dosing support for antibiotics, and we would sort of study what we thought might be going on, identify an issue, propose an intervention, test that intervention, and then evaluate the results. And so we, over the years, built many interesting tools, including the area of pharmacogenomics, which has always been an interest of ours here at Vanderbilt. We managed to write a lot of papers through that process, and then all of a sudden something happened. And so, dun, 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 what was that something? We switched to Epic. And so we are not alone in having made that transition, but now close to 8 years ago, we made the transition to Epic. And that was a momentous occasion for us because we had this 30-year history of making our own software, and then suddenly we were using a commercial system. We were not alone in that, right? So over the couple decades that I've been in this field, EHRs were pretty uncommon, and then over time they've become nearly universally used, and the dominant EHR in the United States is Epic, especially at large academic health systems or places with learning health systems like the University of Minnesota or like Vanderbilt. And so there are good and bad things about this. We were all confessed to being nervous when we decided to make the switch to Epic. We were worried that there could be potential technical limits to how much we could innovate or learn in our health system. We had the source code of our electronic health record software before. So any idea that somebody had, we had essentially full ability to sort of test that idea out. There were some questions at the beginning about what if somebody had a new idea? Would that idea belong to us or would it belong to Epic? Epic had at the time an app orchard, and now they have a showcase. There were also some concerns early on about whether we were allowed to share screenshots, and there were some restrictions on our ability to sort of give demos and show videos and screenshots like I'll do some of today. And these things, it turned out, were, I would say, each of them in their own ways a little bit less problematic than I was worried they were going to be. We found Epic to be very configurable and customizable. We, I think, have kind of figured out the best ways to kind of within the Epic community share the work that we're doing and make sure that other people can use it. Epic has relaxed or eliminated the restrictions or prior approvals that they had on screenshots, and so we can freely share things that we do. So there are also, besides those challenges, there are some really obviously good things about this. So our organization was increasingly spending a lot of time on federal regulations related to certification and regulation of EHRs, and to the point where that would actually crowd out other kinds of development. So I'd make a request and people would say, gosh, we're only working on certification. We've got a new certification test coming up. And so now Epic deals with regulation certification entirely for us, and they can sort of spread or amortize the costs of that across all of their customers rather than just having each customer achieve all of the certification requirements, which means that our researchers can focus on research, our innovators can focus on innovation, our learning health sciences scholars and operators can focus on that work. And I've also found that this then becomes a little bit more representative. Every time I wrote a paper before, I would get some comment from a reviewer, sort of like, look at you in your ivory tower with your self-developed electronic health record system. Um, how would this really work in the real world? And the answer now is, well, it does work. Look, most people in the country are using Epic. And so if we showed that it worked in Epic, I think there's a good chance that it would work at other places. It also means easier dissemination, right? I mostly, my job is to write papers in Jamia and give talks like this, but increasingly I'm also, visiting Epic and talking in Epic conferences and to other Epic customers and Epic staff. And I found that when we build a new innovation that works well in Epic, that we can often get it disseminated to dozens or hundreds of other Epic customers. Maybe, I don't know, hundreds might be a push. Dozens or maybe 100 other Epic customers in a pretty easy way, which is always really, really exciting. And so when it's worth saying, when I got here, there was a little bit of, I think, consternation and worry about how we were going to be innovative in this new place where we had Epic. And so I started a group called the Vanderbilt Clinical Informatics Center. It's really a community of people across Vanderbilt that is dedicated to making clinical informatics research and practice easier to do. So I want people at Vanderbilt to know that if they have an idea, they want some data, they want to test or build a new intervention, that they're able to do that and then evaluate it. So we have many partners, but I'd say two of our key partners are our operational health IT department. I've never worked somewhere where there's such a positive and consistent interaction between the operational health IT department and the academic biomedical informatics department. And so we're really sort of blessed and lucky to have that. And then we also have a pretty well-established learning health system platform or learning healthcare science platform. I know you guys, obviously, that's one of your immense strengths at University of Minnesota as well. But we really enjoy working with them. I think it really sort of goes both directions, right? As we have ideas for new informatics innovations, they help us think about how to study them and rigorously design them and implement them and spread them. And then conversely, as they have ideas of any type, whether those are medications or health system interventions they want to study, often those interact with the HR either in terms of getting data out or even doing studies or even as big as kind of full randomized trials in the EHR. And so we sort of help them use the EHR to the extent of its capabilities. And so that's been a fun interaction here. And so when I was invited to give this talk, I had to think to myself, wow, I would say I'm a CDS or informatics scholar, but I'm nowhere near a learning health system scholar. And so I really thought that given the invitation that I received from you guys, there were three different things to talk about. And I could be indecisive and ambitious. And so I decided to talk about all three of them. And so over the course of the time we have together now, I'm going to try to talk about how we can use decision support to drive change in a learning health system. I feel like in LHS Doctor, I was supposed to have like a sort of circle kind of cycle diagram. I didn't include one, but if you imagine this is the sort of effector arm, we know what to do when we want to use the HR to do it. Conversely, we want to create new knowledge, and so the other sort of side of the cycle here, and then real world knowledge management. So we're going to be producing more and more evidence for our learning health systems. How do we keep that up to date, especially in the context of our electronic health records? So I think I can manage to cover all of these in the time that we have together. So one of my favorite topics is in fact using clinical decision support to drive change. You guys know what clinical decision support is. Basically, it's a bunch of definitions for the government, but it's things that help people make better decisions. And if you remember one thing from my talk, it's that it's not just alerts, right? I think whenever I say CDS, people think of BPAs, or now we're calling them our practice advisors, or OPAs and Epic. There's more to decision support than that. And it is my opinion that the whole reason that we got electronic health records was to do decision support, right? Legibility, better billing, blah, blah, blah. Like those are all great things. And I believe in all those things, but I got them because I wanted to help people make better decisions. So that's really kind of animated pretty much my entire career, is how we can do good decision support. And there's ample evidence, as you guys know, for the benefits of decision support, including from a systematic review by my colleague Tiffany Wright. There's some federal incentives or pressures to use decision support. We also know that there are some challenges with decision support. People overwhelmingly are likely to override, particularly alerts that we give people. When people overrode alerts, I used to sort of sit in my office and be mad at them, and I would look at what they were doing, and it turns out that there were often exceptions or special cases that I hadn't taken into account. So in many cases, when people override my decision support, they're right and I was wrong. And so I think that that's important. Decision support can also interrupt people's workflow or train of thought. We have a big department here that I help lead that maintains all the decision support, and so the personnel requirements are important, especially as guidelines are constantly changing and our learning health system colleagues are creating new knowledge and new evidence at a sort of breathtaking speed. And we've got to make sure that we keep our decision support up to date. So those are some of the challenges of decision support. And so I'll give you guys just a quick example here. This is something we studied in our learning health system, which is sort of sepsis. You guys know what sepsis is, but basically you have an infection. That infection is somewhere in your body, and then it enters the blood and leads to organ dysfunction and then can lead to death. And sepsis is a medical emergency that's we've known for a long time. As it takes longer for us to start antibiotics, people's survival rate decreases. If we start them right at time zero, there's a greater than 80% chance of surviving sepsis if we wait till 4 hours to start antibiotics, which is about the median time it takes us to start antibiotics in patients with sepsis. There's only a 50% survival rate, and as time progresses, that gets worse. And so there's obviously a lot of reasons to imagine that we might want to improve sepsis care. And so I have a very expansive definition of what decision support is. And so one very straightforward kind of decision support is actually not even in the electronic health record. We could sort of put posters up on the wall or attach something to your badge reminding you how to treat sepsis. And I would call this information, a relevant information display. This could also be done in the electronic health record, right? We could have hyperlinks to relevant guidelines. So I would call this decision support, even though it's a pretty basic type of decision support. Stepping up a level, we do have these alerts. We sometimes use predictive models to make these suggestions. So this is an Epic sepsis model alert that suggests that this patient has a rising lactate and is tachycardic, and I think has a relatively low blood pressure, and so maybe experiencing sepsis or septic shock, or at least meets the SIRS criteria, and should be evaluated appropriately. And so if you get that, then it takes you to these order sets, and order sets, in my opinion, are another form of decision support. I think they're an underrated kind of decision support because we sort of build them and we say, and it's true, that they're there to help you order things faster and sort of do your job, but they're also a really potent way to actually steer people towards doing what we want them to do, because people tend to accept the defaults in our order sets and not order as many things that are off of the order set. So here at Vanderbilt, if a patient has sepsis, you can order some labs for them, like a lactate, which actually you'd order 2 lactates. you can try to start some antibiotics. And so in this case, I said that the patient has community-acquired pneumonia, and it steers me towards Vanderbilt's recommended antibiotics for patients with community-acquired pneumonia, whether they do or don't have a fluoroquinolone allergy. If I'd said that it was from the skin infection or from a urinary tract infection or something like that, I would have gotten different recommendations for antibiotics. But we sort of took our knowledge that we developed locally and through national guidelines and tried to implement that here. However, we don't always know the best things to do, right? So if I look back at my badge buddy here, it says that I should start giving a crystalloid fluid. And we didn't know necessarily what the best IV fluid was. And in fact, we had a couple of choices here. So my internal medicine colleagues liked to give normal saline, and my surgeon colleagues often gave lactated ringer solution. And there was very poor evidence for which one was best for patients. There hadn't been a lot of clinical trials. The observational studies were difficult because the patients that got LR were very different than the patients that got normal saline. I actually had some internal medicine colleagues that would like make fun of surgeons for using LR. They called it IV fluid for jocks. But it turns I know there we got the surgeon Genevieve back there has a belief about that. So, anyways, we did a learning health system trial here at Vanderbilt of these two IV fluids, and so in both our ICU, which I'm going to talk about here, and then our emergency departments, we basically randomized some patients to get lactated ringer solution, some patients to get normal saline. And in this case, we sort of alternated back and forth each month. We gave some patients the normal saline and some patients the lactated ringer solution. And we were impressed or surprised to discover that, in fact, my surgeon colleagues were correct, and lactated ringer solution was superior than normal saline for our patients, especially as it related to a kidney injury. And so we knew something new, and I would argue that our learning health system sort of taught us this new thing. We managed to get a paper in the New England Journal about that, and then it was time to actually sort of implement this. So at Vanderbilt, before we did this trial, about 60 to 75% of patients were getting normal saline. This is the kidney poison that we proved was sort of dangerous. And then this was the trial we did. You can see it sort of whiplashes back and forth during the study as we were encouraging either normal saline or lactated ringer solution. People were mostly doing the thing in our pragmatic trial that we were telling them to do. And then the trial was over, and largely impacted sort of baseline behavior. 75% of people were back to ordering saline. We published the trial, and then even more important than that, I would say, we decided we were going to use the electronic health record to be the efferent arm of the work here. And so we updated the order sets to tell you to order lactated ringer solution, and you can see here that we only offered these balanced solutions. And in fact, if I tried to order a normal saline bolus, I would get an alert that said, "Hey, Adam, we showed based on recent evidence from Vanderbilt, lactated ringer solution or plasmolite normosol as the preferred fluid." And so we appealed to evidence. We told people this is Vanderbilt specific evidence. Right here at Vanderbilt, we proved that this was the superior. The surgeons were right, exactly, Genevieve. We proved that this was the superior thing. We encourage you to remove the sodium chloride that you ordered and replace it with a bolus of either lactated ringer solution or normosol. And so this to me felt like it covered kind of the full extent, or at least many of the aspects of a learning health system, right? We didn't know the answer when we were making the order set. We said, let's get some evidence. We used a pragmatic trial design, including in addition to some observational data to kind of create some new evidence. And then we used the EHR to help deliver that and ensure that people were sort of following along. And so that led to an enormous drop in the use of normal saline here, down to our goal of less than 20%. It turns out that there are some exceptions where it does make sense to use normal saline. So we still give people obviously the option to do that if they want to, but we were able to kind of dramatically change practice through a combination of new knowledge, right, that LR was better for patient outcomes than normal saline, and also through decision support to kind of offer both a default option in the order set to make it easy to do the right thing, and then as a safety net, an alert that kind of strongly encouraged you to do what we thought the right thing was for your patient. And so this to me felt like a learning health system victory, and this was done by our learning health system team here, led to some good publications. So that is the kind of CDS is the efferent arm piece, although I did sneak in the LR trial. I'm going to talk about another trial that we did very, very recently that really used as many features as possible of the EHR to conduct a pragmatic trial. So I'll confess to you guys that the trial design was pretty straightforward for that normal saline trial, where we just, for each ICU, we said, okay, in even months, you guys use LR, and odd months, you guys use normal saline, and switch for the other ICU. This one we really actually did patient level randomization and worked directly in the electronic health record. So this was the ACORN trial that came out, gosh, at least a year ago now. But we had similar equipoise, which is for patients who had sepsis. What was the best antibiotic to give them? And if I asked some of my colleagues, they would say, I like to give cefepime. Others would say I like to give piperacillin and tazobactam or Zosyn. And there were some concerns that cefepime might introduce this phenomenon that people refer to as cefepime-induced neurotoxicity, which is controversial. Some people think there's no such thing. Other people think it's terrible. Similarly, Zosyn or Tiptazo is thought or known in some ways to potentially cause acute kidney injury. And so we have this kind of bad choice between harming the kidneys or harming the mentation of the patient. And so we didn't know what the right answer was. About half our doctors were using cefepime and half were using Piptazo. And so we decided we were going to build an alert here. And so there are 5-ish phases to a clinical trial: screening, enrollment, randomization, monitoring, and the outcome assessment. And we decided that we were going to do essentially all of these directly in the electronic health record. And so we had an outstanding pulmonary and critical care fellow, my colleague Eddie Chen, and he decided he wanted to do this, in my opinion, very ambitious clinical trial as part of his clinical fellowship project. And the only way we were going to be able to afford to do it was using the electronic health record. And so Eddie did all the physician builder training and clarity and data analytics training needed to get access to build this trial in electronic health record, and he was able to do it. And so for screening, we tried to identify patients who were eligible for this study, and it's a pragmatic trial. And so one hallmark of a pragmatic trial is we wanted to have as many eligible patients as possible. So we had a pretty broad inclusion criteria. Basically, almost anybody who was getting either an order for cefepime or Piptazo in the ED or the ICU would receive this alert, and we would basically say, how would you feel if we just took your order away and then we randomly picked an antibiotic for the patient? And you could opt out of that if you thought that there was a good reason to use one of those medicines, or you just didn't want to include the patient in the study. And to our delight, I think people appreciated there was equipoise here, and a large percentage of them decided to accept the alert and let us randomize the patient to get the study drug. And occasionally most of the inclusion exclusion criteria were able to implement directly in logic in the electronic health record, but there were some things like, are you a prisoner right now, that were hard for us to necessarily know from the EHR. So there was some manual exclusion that applied. For the most part, we were able to do the screening and enrollment stage directly in the EHR. And this particular trial, given the urgency of starting this antibiotic, according to those guidelines that I shared with you earlier, was done with a waiver of informed consent, or a modified version of informed consent, thanks to the analysis of our IRB that they thought that this would be an ethical approach. Enrollment was basically just enacting the randomization once the surgeon hit the button to successfully screen the patient. We then assigned them the antibiotic that they were randomly chosen to get, and we had some monitoring tools in place, including a report that Eddie ran basically every day or multiple times a day to make sure that patients were accruing in both arms and getting the antibiotic they were supposed to get. If you tried to order the not the right antibiotic for the patient, so let's say that I had randomized the patient to Zosyn and you ordered cefepime, we would try to remind you the patient was in the trial. We would obviously defer to your judgment, but we tried to sort of, as much as we could, where it was clinically appropriate, keep the patient on the arm that they were assigned to. So we had some monitoring tools, and this led to a paper in JAMA and some very positive results. You can see first off that the pragmatic learning health system trial worked as expected. So you can see very similar characteristics across the two arms of patients, and people almost always got the antibiotic that we randomized them to. So you can see that for the patients in the left panel that were randomized to cefepime, they mostly got cefepime. For patients who were randomized to piptazo, they mostly got piptazo, which was our goal, which suggests that this EHR delivered randomization and intervention was had high fidelity to what we had assigned the patients, and the outcomes were actually pretty provocative. So what we found was that there was a relatively low rate of acute kidney injury in the piptazo group, actually maybe lower than the people had thought, and that the rate of AKI in the cefepime group was actually quite similar, essentially not at all different between the cefepime and piptazo group. So that was encouraging in the direction of piptazo as perhaps not as injurious to the kidneys as people thought. There were some subsequent studies that also suggested that the piptazo was not as bad for your kidneys as we thought it was. We looked at several secondary outcomes related to kidney function, and again saw basically no difference. And what was very interesting to us is that I think many of us had actually thought that the cefepime-induced neurotoxicity idea was not very realistic. But what we found, in fact, was that there were more days of delirium and coma in the cefepime group than in the piptazo group, supporting the idea that cefepime may actually cause this phenomenon of cefepime-induced neurotoxicity. And so the conclusion of this study was that Zosyn was actually probably a superior choice for most patients than cefepime, because it doesn't cause the cefepime-induced neurotoxicity, and the harm to the kidneys was not as prevalent as we thought it was. So we were able to both show a clinical result here, and then we were also able to at least demonstrate the idea that we could do a whole prospective randomized trial in the HR as a fellowship project, which I was not quite sure we'd be able to do. And so Eddie has started to make a whole career out of doing these kinds of trials in the HR. But people would get grants for $5, $10, $15 million to do trials of this size, and hire armies of research coordinators and trial staff, and not accumulate or enroll patients nearly as fast as we're able to with this. So it's my dream. We're not there yet, though. Vanderbilt will be doing 50 trials like this at a time. Whenever there's a question that we have where there's not strong evidence, that we would be able to do a real trial. And to me, that's a real manifestation of the idea of the learning health system, is that as we have these questions, we're constantly exposing them to high quality evidence generation, sometimes observational, but in many cases, prospectively assigned or randomized, like in these trials. So my second point is we can generate a lot of high quality evidence in our learning health system by using the electronic health record and using decision support. And so I wanted to close with some ideas here about knowledge management. And I would be a bad decision support professor if I didn't point out that there are a lot of rigorous and robust papers and books out there about how to do knowledge management for decision support. As is popular, they often have cycles in them. I wrote at least one of these papers with some other colleagues, and you should follow a long and rigorous, good process for maintaining your decision support. But I want to actually focus today on some practical things that I feel like really shorten the cycle between our decision support interventions and the sort of creation of new knowledge. And I just wanted to clarify one thing. Dr. Melton Mukes asked if the screenshots that I showed had any PHI in them. They do not. Every screenshot that I showed is a test patient from our Epic test environment. So anything you see here does not have any PHI in it, if anybody's worried about that. Great question. So coming back to the slides here, this was an alert that people received in the electronic health record. It was evidence-based, so patients with coronary artery disease or an equivalent like diabetes on their problem list should be on a beta blocker, and this patient was at least ostensibly not on a beta blocker, so the CHR alert was suggesting that they be placed on a beta blocker. And you can see this alert on the side here, so that's the alert, and then on the left side is their medication list. And if you carefully read this, you may notice that the patient is in fact taking a beta blocker. They're taking carvedilol or Coreg, which is a combined alpha and beta blocker. So this is an error in the logic of the decision support tool. And this happened because in the drug classification system that we were using, since carvedilol has both combined alpha and beta blockade activities, it was placed into a special class called combined alpha and beta blockers rather than the beta blocker class that we were expecting, which is a classic mistake that I think we've seen again and again in the decision support literature. And so we had a helpful user here who decided to override the alert appropriately. I told you that many CDS overrides are appropriate, and he indicated that he wanted to write a comment and wrote patient is taking carvedilol, but I think was at the end of a shift or generally feeling frustrated with the HR, so added on, you idiot. So this was his, I guess, shot across the bow of our decision support team. And at the time, we actually didn't really have a prospective ongoing way that we monitored the comments from users. And so I decided to take a look at all the historical comments, and I found some real gold in there, right? So she was taking insulin already, you are stupid, long-standing accuracy with Epic. And so it turned out that users were giving us rapid feedback on the decision support. And we at the time didn't have a prospective way of monitoring that feedback. So we built an email. I look at this email every day. I read it in the morning with all the comments that were given on the decision support yesterday. And we use a pretty simple NLP tool to classify the comments as cranky or not cranky. And so I highlighted one in yellow here. This was a cranky comment. It says this is a wrong PPHS CT has been ordered. And I took a look, and surely this user was correct, and we were wrong. And so this patient had an elevated D-dimer, and they needed a CTPE, and they had been ordered a CTPE, but they were at one of the outlying community hospitals, and it has a different code in the electronic health record than on the main campus. And we had done a incomplete job of curating the list of codes that meant CTPE. So we were alleging this patient hadn't had a test that they had had. And so helpfully this user sent us that feedback. And then the thing that really I think caught them off guard was we now read this feedback. I replied to them the next day and said, so sorry about that. Thanks for your feedback. We fixed it. Let me know if it happens again. And people are just like amazed when you write to them. A lot of people have no idea that there are people at Minnesota or people at Vanderbilt that are building this decision support. A lot of people actually seem to think that Epic Systems Corporation in Verona, Wisconsin makes all the decision support in the HR. But the secret truth is that we actually make it at our sites using tools that Epic gives us. And so people are just like thrilled to hear back from you. Sometimes I can't even fix their problem, right? I mean, there's a technical limitation or there's some issue with how they document it or something like that. But just to know that there's a real live informatics human on the other end of the line makes a big difference to people. So we monitor this every day, and we've had some really quick kind of cycles of improvement as a result of this measurement. So this is my take on real world knowledge management. And so I'm going to stop here. I had some more slides, but what I want to do is leave some time for questions. I heard from Genevieve specifically that you guys asked some great questions. And so I'll stop here and see if you guys have anything to ask. And if not, I can tell you about a few more things. So I look forward to hearing your questions.
Maybe I'll
right.
start us off. I'm curious, like, is this on every single piece of decision support? Is it only the alerts or a subset
Yeah.
of the alerts? How did you all
So
decide?
yeah, so for the comments, there are actually two ways that we do that. I'm actually going to share this again to show you guys. So when you override an alert in Epic, you have the option to write a comment. This is like a built-in feature in Epic, as you see here. And so you can sort of do that. And so those comments really primarily exist on our best practice advisories. However, other types of decision support in Epic can also, I'm just trying to pull up the right slide here, get feedback. And so this was, let me go back to the Acorn alert here. You can see in the upper right corner, I have this smiley face phenomenon. And so this is basically a way that you can kind of upvote or downvote the alert. You can say you enjoyed it or didn't enjoy it, and send me a comment. And we've actually placed these in a lot of places. So these are on our best practice advisors. They're on some of our order sets. They're on some chart review templates. And basically now, whenever we build a new tool in Epic, we add these feedback icons. And I will tell you guys that I get a tremendous amount of useful feedback from people when we display these things. And I'd say probably half of the feedbacks that I get are actionable in some way or another. In fact, we made some changes to decision support yesterday as a result of some of the feedback that we got from users. So that's been tremendously helpful from my perspective. I'd also say, just since we were talking for a second about Epic as partners here, is we learned about some of these ideas from other Epic customers. We presented this in Epic forums, and Epic actually added a native feature in their EHR where you can give people thumbs up or thumbs down on the feedback, on the decision portals, at least in Epic. And so it's really fun to sort of see something that we came up with and implemented, actually make it into the product, and now be used by all, few hundred of Epic's customers across the country. So I would say that's actually been a secret mode of dissemination. I saw that Michelle Stoffel was on the line, and when she was in her fellowship, we actually collaborated on implementing this at her hospital. And so it's been fun to be part of an Epic community where we sort of share knowledge with other Epic customers and also are able to implement these things as kind of native features in Epic. So that's been, in some ways, like a highlight of my career, is seeing a few things that we developed make it into the core Epic product.
All right, it looks like we have a question from Rubina. She says, "Thank you for the wonderful talk. I'm interested to learn more about usability evaluation of tools you develop at Vanderbilt." One of her questions is, how did you ensure during the development of the clinical decision support tool that it aligned with user requirements and integrated smoothly into clinical workflows?
Yeah, I think that's a great question. So we are lucky to have with us a usability and human factors team at Vanderbilt. We call them CRIS, the Center for Research and System Safety. And so we do almost all of our project with some engagement from human factors personnel. And so we regularly design things using a user-centered design process. We try to do co-design. I think we've really dialed in the process of co-design with clinicians like physicians and nurses. But interestingly, we also increasingly use community engagement studios and other processes to involve patients in the co-design of these interventions. And so that's been, I think, pretty useful for us. I regularly learn that things that are really obvious to me, and of course they make sense, are not clear to other users. We had some decision support related to medication reconciliation, and it turned out that there are several steps in the medication reconciliation process, and people didn't always appreciate, we were giving them alerts saying, hey, complete medrec, and like, I thought I did, but they didn't realize there were two more steps or something like that. So that's been pretty helpful for us. And I would say, though, that in addition to kind of formal usability testing, having some feedback loops where once the thing is live, people communicate to you has been a helpful adjunct for trying to improve or better understand the usability.
Next, it looks like we have a question from Layla that says, were you worried about the volume of feedback you received in comparison to how many alerts you have in the system?
Oh, hi, Layla. So I think that's a great question. I was a little worried, but I'll confess I was also a little bit worried about the volume of alerts that I had in the system, right? And so I felt like if I was going to sort of interrupt your day and tell you to do something, I had better be prepared to sort of hear and read the feedback that you sent me. And so I was worried I was going to get a lot of sort of miscellaneous grumbling, like, oh, there's too much EDS or something like that. Maybe there is, but it was extremely helpful and encouraging to discover that, in fact, the amount of feedback we got was manageable. I read it along with some staff on our decision support team. We haven't really felt overwhelmed by it. We have done a couple of things like that cranky comment finder, and then increasingly, since everything has to revolve around ChatGPT, we're actually using LLMs to summarize the feedback and try to find trends. And so, like a lot of you guys, we use a version of a large language model hosted by Microsoft on the Azure platform, subject to a business associate agreement. So if there's any PHI in the comments, it's sort of safer to analyze that there. So I would say that there probably is a role for technical kind of LLM-based approaches. Because I would also say that if we have so much decision support that we can't read the feedback from the users, either we have too little staff or too much decision support. I think it's almost a promise that we ought to make you that if we're going to alert you and interrupt your workflow, we have to be ready to hear your feedback about it. It's a great question, Layla.
Next,
Same
we have
question. Oh, you go ahead.
Oh, sorry. Next we have a question from Joe that says, "This was a great presentation. Thank you. In addition to user feedback, is there data you review to evaluate the effectiveness of existing interruptive alerts like data from Slicer Dicer?"
Yeah, I love that question, right? So the feedback from users on the alerts that we get through the feedback mechanisms is sort of qualitative, and it's inconsistent, right? And we don't get it for every alert. We get it only when users decide that they want to give us some of that kind of feedback. And so we regularly use tools to evaluate the effect of our decision support. And for a long time, we used a Tableau dashboard that we made at Vanderbilt that was like pretty helpful. And then again, in collaboration with Epic, they sort of improved some of their slicer dicer capabilities for analyzing the impact of decision support tools and release those to customers. And so every customer now has access to the alerts data model and slicer dicer. We use that regularly. I'll just tell you guys, since we're friends here, that we used to visit hospitals and ask them about how they monitor their decision support. And there was this common phenomenon where they would say, "Oh, our CDIS committee used to get these great reports about how often the alerts fired and how often they were accepted, and then insert someone's name, retired, and after that, no one knew how to run that report anymore." And so that always broke my heart, right? I again felt like if we were giving decision support to people, we owed it to them to look at sort of how often it was firing and what the actions were. And so we're really happy to see Epic, and Cerner has done this too, and other EHR vendors, to improve the quality of our reporting tools. And I would say that it is essential, if you're a decision support maker or practitioner or researcher, that you regularly monitor this data. The other thing that I'll try to squeeze in here, if you can tell I have this orientation towards randomized trials, is that we have a lot of decision support. And we have data that says people accept the alert this often or they override the alert this often. And that's really useful information. But I'm here for the impact, right? It is the impact seminar, I guess. And so I want to know the decision support that we're implementing is effective. And so we regularly do randomized trials of decision support tools, and the results are not always what you expect. There are things that have relatively high acceptance rates that don't really seem to move the needle very much, right? Like, we often give a lot of flu shots, and so our flu shot alerts have a high acceptance rate, but it turns out that if we don't show the flu shot alert, we still give flu shots because people kind of know to give flu shots. And so that would be an example of an alert with a high acceptance rate, but a relatively low impact on clinical outcomes. We have some other alerts for rare but important conditions that are don't fire very often and accept that many times in a year, but the right population of patients move the needle quite a bit. So I would argue that in the same way that we've decided that a new medical device or a new medication deserves a rigorous evaluation, including with the benefit of a randomized trial, that decision support interventions in many, if not most cases, ought to have randomized trials too. And I think that the reason that we don't do that often is the sense that a randomized trial is this immense effort that couldn't possibly be done. And obviously it can be an immense effort. But we found that by working with our LHS colleagues, that they've helped us understand what it would really take to do that and do that in a proper and rigorous way. And we've actually found that given the availability of HR tools, that we have been able to do that in a more scalable way for more CDS tools than I would have guessed. In fact, I'll tell you guys right now that one of our current interests is randomized de-implementation of decision support. So could we go through our catalog of decision support things, turn them off for half our users, and see whether there's any drop in the performance of the related quality outcome. So that's where my heart is how could we use RCTs to actually show clinical impacts.
All right. It looks like we also have a question from Sarah that says, "What is your process for managing CDS tools long term? For example, as recommendations change or updates are needed, who owns the responsibility of making sure they are
Yeah.
updated?"
Sarah, this is so hard. I mean, to answer your question as directly as possible, every decision support artifact has a owner. We have a regularly review schedule, and we'll ask the owner if there are any updates and if they make any changes. The owner writes back to us about half the time, and sometimes they went somewhere else or have a new job, or they finished their fellowship, or they're just really busy. And so a fair amount of our work is, in fact, sort of chasing these things down. Plus, evidence doesn't just get created on an annual basis, right? There's no new evidence, and then suddenly there's some practice changing thing in the middle of the year. And so I will tell you that we have a handful of processes. We try to sort of monitor the literature. We regularly poll the subject matter experts that help us with these things. I watch for up-to-date practice changing updates, and I make sure that if there's anything new there, that I try to ponder the decision support. That is limited by the size of my capability to remember all the CDS we have. As we have more CDS, I'm doing less and less of a good job of remembering all of it. And so if I were an informatics or learning health system PhD or master's student right now, I would be trying to do some work looking at things like large language models. And could we index our decision support and index our new knowledge that's coming in and try to say, look, a new seminal trial came out of the New England Journal about topic X, and we have an order set about topic X. Should we make a change to it? And so I just gave you guys my $1 billion idea, but I think that that would be something that we should probably be exploring, because I think that we are rapidly approaching the limits of human cognition for maintaining the decision support.
Let's see. We have a question from someone that says, how many team members are observing feedback you receive from clinicians?
Yeah, so that's a really good question. And the most direct answer to the question is 7. So there's 7 people that are responsible for monitoring the feedback. If we were doing a really good job, we would have some sort of formal rotation and process, and we would say, like, okay, on Tuesdays, Bob is in charge, and on Wednesdays, Cindy is in charge or something. We all monitor it. And I think I've heard the joke about, like, how do you kill a cat? Ask 2 people to feed it. And so I'd say are doing a pretty good job. We certainly managed to get all of these sort of angry comments or cranky comments, or the comments that are sent directly to us through the smiley frowny face function reviewed. I have been playing around with ideas for, could we have a formal on-call rotation and a ticket management tracking system for all the feedbacks, and that'd probably be a good thing for us to implement that. But the short answer to your question right now is 7 people are monitoring it.
Next, Melissa says, I have been working with the cardiologist at Essentia Health on to try to achieve NIH funding for developing an in-house CDS in Epic. Given the challenges in achieving NIH funding at this time, we will be seeing if Essentia will support this development in-house. Do you have a recommendation on the range of hours required for CDS development on the Epic programming side? Ongoing maintenance and tracking user comments would be a later budget focus.
Yeah, this is the dreaded sort of ballpark question. And so I think that the correct answer is it really depends on the nature of the intervention and stuff. But I would say that we operate a clinical informatics core service in our in vClick that helps with projects like this. We probably usually budget around 150 hours for these kinds of things, often as a worst case scenario. Sometimes if they're pretty straightforward, depending on the complexity, we can do them in as few as 20 hours. I would say we have a large physician builder program at Vanderbilt where physicians go and get trained and certified to make changes in the Epic EHR. And those projects often go a little bit faster just because the physician is typically very familiar with the workflow and the clinical content and groupers and logic needed. So if you guys can find or become builders, I think it's probably faster. But if I try to make up a number for you, I'd say 150 hours. And if you email me, I'd be happy to tell you what we'd estimate here at Vanderbilt. My email is adam@vumc.org.
Let's see. Next, we have a question from Tom that says that is very impressive that a physician builder was able to build the infrastructure for the Acorn trial. Did this require special approval from your health IT department, or can all of your physicians builders build up in PROD up to the level of their Epic
Yeah.
training?
Tom, I love this question. So Vanderbilt has about 100 physician builders. We have one of the largest builder programs in the country. And it was really the CEO of our health system, Jeff Balzer, that set this goal of having a large and active builder program. And so builders at Vanderbilt who get trained are funded generally by their clinical department. And when they do the training, they can come back and they're allowed to build. And the short answer is they can build pretty much anything they want in our POC, our proof of concept environment, and they can migrate it to our testing and support environments to sort they're tested in the real world. They do need cooperation from our health IT teams to move things into production, and we do have some governance processes. But what I would actually say is that we have a lot of deference to the clinical leadership in areas. And so when Eddie said, I want to do this trial in the MICU and the ED, and here is an email from the MICU medical director saying that the MICU wants it, and here's an email from the ED medical director saying that the ED wants it. Who are we on the CDS committee to tell them no? And so I would say that when we have the consent of the alerted, we tend to be pretty deferential to those requests. So in that case, Eddie came to us. He had already gotten buy-in from the senior leadership in both the ICU and the ICUs in this case, and the ED. And so we said, we did a quick check to make sure it seemed like it was built correctly and gave some feedback. And then we said, go for it, turn it on. And so Eddie doesn't turn it on. His paired analyst buddy turns it on. But in general, the request that worries me is when somebody from anesthesia comes and says, those surgeons aren't doing this thing I want them to do before the case. Can you put a BPA in to remind the surgeon to enter this type of order or something? And so we tend to kind of push those requests back a little bit and say, why don't you go find a surgeon and then come and co-present this to us about the way that you've designed this? But if an anesthesiologist and surgeon came to me and said, we want to build this new alert in the system, and thought it was a bad idea, I'd probably tell them and I give them my best feedback. But if they really wanted it, I think I'd let them have it.
All right, we'll do one more question. Rubina asks, did you face any challenges while redesigning the Epic BPA where many elements are often hard-coded? How
Yeah.
did you address those challenges?
That's a great question. And so, for people who've been around for a while, Epic has these alerts called BPAs, or now they're calling them OPAs, or our practice advisories. And there was a time where you had to do a lot of sort of hard kind of system level mumps programming to implement them. And over time, they've expanded the capabilities of their BPA or OPA editor, and they have made it more possible to kind of customize the display and appearance of the BPA, where it triggers, the logic it uses, the actions that it offers the user. And I think now most of the time find that we can achieve a lot of our goals. And I would say, again, I think Epic's been a good partner for this. So if you look at the alert that I have on the screen right now, there are these are sort of mutually exclusive choices. You probably only choose one. And so we gave some feedback to Epic saying, hey, we don't like that. Like, it is possible to do both of them at the same time if you want to. And then we worked closely with them on what they're calling decision-centric advisories or decision-centered advisories, where now you can use radio buttons here, only select one thing. So what I've personally found is that when we encounter limitations with the BPA or OPA system, we talk to Epic. I meet with Epic's CDS R&D lead every month and tell them what I think is working great and what I think could be improved. And I found Epic to be a good partner for improving those things.
Well, thank you, Dr. Wright, for taking the time to give this talk, and thank you all for attending. Again, in closing, please join us for our next seminar on October 7th at noon Central Time. This concludes our presentation. We'll see everyone next time.
Thanks, friends.